In episode 20, we're going to try and create a different timeline than the one presented in court. On this timeline, we'll try to explain what was actually happening to the baby when these so-called incidents took place, and in between the events or incidents that the prosecution used to accuse Letby. So we remember their theory is that damage only occurred to the babies when Letby was present. But that flies in the face of what we know about medicine. We go back to baby was born on the 20th of June, and we don't have any disagreement on that. We also know that the mother has said she has 50 hours of premature rupture of membranes with no antibiotic cover, and that to attend the hospital on 2 occasions before anyone took her seriously, that she's being examined by 2 different doctors, one of which treated her with respect, the other which didn't. Eventually she's put up on a drip, and we have the expectation of labour. Because the membranes have ruptured so long, labour should have started, but it didn't start. And then remember that the mother said that the baby was lifeless, white, lifeless, what we would say flat as a pancake when the baby was born, and she was transferred to a postnatal ward and then moved to another postnatal ward while no attention was paid to the baby. What we have here is 3 events. We have the premature rupture of the membranes that went untreated. The second one, we have the unlikely inoculation, so that's the introduction of the pathogen into the womb and give signs of distress in the baby. We likely have the transmission of the pathogen to the baby. So Dowie Evans referred to this, the so-called expert, as antenatal pneumonia. Well, antenatal pneumonia is pneumonia in the mother, not in the baby. This was neonatal pneumonia. And it's reasonable to assume, because there was concern just before the start of the cesarean section, that the baby wasn't doing well in utero and that they couldn't afford to wait any longer. So it's a reasonable deduction that baby D had acquired pneumonia in utero. So what processes were going on then? The common routes of infection are through the vagina and the cervix into the uterus. And that would be the first stage. Colonization then of the membranes that surround the baby and the fluid that supplies the baby. Chorioamnionitis. So this starts to kick in other events. We have hypoxia. So hypoxia is almost certainly present from the very beginning. So hypoxia results in a switch, as we know, to anaerobic respiration from aerobic respiration. We've dropped down 35 to 1 in our ability to easily produce energy. We now have a compromised membrane between the mother and the baby for the exchange of nutrients and gases and waste products. So all of those are now building up, creating an ever more toxic environment for the baby. So the first thing we're going to get with the infection and the damage being done by the hypoxia and the damage being done by deterioration of the chorioamniotic membrane, we're going to get inflammation. So that's the other event. So we have 3 significant events going on here at the moment. We have damage to the amniotic cavity, we have damage to the lung, and we have damage to unknown and other organs because of hypoxia, all of which are now inducing a physiological process called inflammation. And this inflammation is going to go on to produce exactly the picture that was found at postmortem. So the severity and the progression of the infection will depend on the gestational age and the duration of the membrane rupture, but we know in this case that was very long, and also the virulence of the pathogen, and some of us suspect that these pathogens were opportunistic Pseudomonas or other gram-negative, opportunistic pathogens that like sewage, actinobacter, things like that. We don't know, but again, the unpredictable maternal and fetal immune responses we cannot quantify at this point, but we know that they're not good. But these are an event, a continuum of disease that is now established in the baby, and they make these little events that the prosecution talk about, they just put them in context. But it is absolutely wrong to isolate those so-called events from any serious pathology that was occurring in BBD. And at this stage of infection, when it's early on, that's known as the prodrome phase, we would not necessarily see specific signs. So if you have a cold or a flu, your symptoms are vague, fatigue, headache, bit of fever, but we don't really know what's causing that at the moment. And that's always a problem with infection. The prodrome phase can lull you into a false sense of security, and it can be brushed off. And doctors can brush it off quite easily because they're not thinking wider than they should think, and they're not thinking in the context in which they should think. So the prodromal phase in this case should have had the consideration there of the state of the mother, the fact she's pregnant, the fact that the membranes have ruptured. But none of that's taken into consideration because she's gone 50 hours plus without antibiotic cover, and the point of the antibiotics would be to reduce the mass of the pathogen that can grow from the initial inoculant. So from the initial infection, the antibiotics would suppress the expansion of that growth of the pathogen and consequently reduce both the impact of the infection and the consequent inflammation. That didn't happen. When the baby was born, the baby collapsed not long after birth or around the time of the birth. The baby therefore had birth asphyxia. So now we have acidosis and we have damage happening because of hypoxia, and still the baby is not given antibiotics. So these pathogens are just eating up whatever organs they have found their way to. And unfortunately in this case, which is common when this type of thing happens, the lung happens to be the location where the pathogen concentrates most and produces pneumonia. Now, there was an X-ray done not long after birth, but I can't find any evidence that it was repeated. And the lung suggested a syndrome called transient tachypnea of the newborn, which does not fit the clinical picture here because transient tachypnea of the newborn would not progress. It usually resolves within 12 to 48 hours. It doesn't progress. It's highly likely that the X-ray that was initially taken demonstrated pneumonia and not transient tachypnea. So that's another event, the missed opportunity to diagnose pneumonia. And pneumonia is incredibly dangerous in babies. And you would usually get a period of decline where you can see the baby getting sicker. And that is borne out by the major event that was not classified as an event, the decision to intubate, to actually use invasive ventilation in BBD. So we recall the mother was left from 4 p.m. on the 20th of June to 7:30 to 8 p.m. without any attention and with people telling her that she was imagining things. And then we have the decision to intubate at 8 p.m. on the 20th of June. That's a major event. But then all kinds of weird things start happening at that stage. So in order to understand what's happening at this stage, we likely have, don't forget now, we've got infection, hypoxia, acidosis and inflammation all going on, all likely accelerating here at this point. As I say, the mother's statement is vital for people to read to understand what's going on here. But we'll go to the examination and cross-examination of Nurse Caroline Oakley, because we've suddenly catapulted on in this trial to the night of the 21st and the 22nd without going into any detail of all of the damage that is already present in this baby on the night of June the 20th, the day it was born. So let's see how these two, the examination and the cross-examination, really start to diverge, where one is attempting, that is, the defence is attempting to establish some kind of reality to what's going on with baby D, and the prosecution keeping us down in the weeds and leading us up garden paths about text messages and stuff like that. So Ben Myers gets Nurse Oakley to admit that she was on the night shift of June the 21st and 22nd, and she was the designated nurse for baby D on that night. So we also know that the designated nurse thing is as much an administrative thing as anything else. Mrs. Oakley says she does not recall which nurses were designated nurses for each baby that night. Her nursing note, written retrospectively to 4:46 a.m. on June the 22nd for the night shift, is presented to the court. So this is overnight between June 21 and 22. And her first thing at 4:46 a.m. that was written retrospectively was at the handover, the lower limbs were dusky and the feet bruised, and the doctors were aware. And the feet were cool to slightly warm. Observations satisfactory. Those are not satisfactory observations. We have feet cold. We have lower limbs. What we have there is signs, the very first signs of compensated shock. So what happens in compensated shock? And this will go on to explain why this baby collapsed in the way that it did. We'll just get a little bit more detail before we go into this description of compensated shock. She said she was monitoring. She said it was something to monitor. This is another thing that you read all the time. It's just something to monitor, but not a concern at this stage. It is a concern at this stage. This baby is not in good condition. And those observations were relayed to the doctors. Well, if it wasn't of concern, why would they relay them to the doctors? And the nurse said BVD's circulation was not 100% brilliant at that point. But this was common in newborn babies. This is not a common newborn baby. This is a baby who was flat as a pancake at birth, who went 4 hours without any help, and then went straight onto a ventilator. And we're told here that the circulation isn't 100% brilliant. I don't know what that means, but what it really means to me is that the baby is in established shock at this stage. The note records BBD was reviewed by Dr. Andrew Brunton. The decision was made to commence feeds and increase as tolerated with express breast milk. Blood gas readings at 11:52 p.m. and 1:14 a.m. were satisfactory, but these blood gas readings are only part of the big picture. They're not something that we should keep an eye on, we need to monitor. But we do notice that they have been lulled into a false sense of security here. So Mrs. Oakley says that she can remember being very happy with her on the night shift, while BBD was an intensive care patient in the neonatal unit. She was only requiring a little assistance with breathing as she was stable. So this is a baby whose circulation is not 100% brilliant, who's had such a horrible birth, who got antibiotics late, is on a ventilator, and she's nice and stable. No, she's not. The observation chart for the child D for the night shift is shown to the court, which shows Caroline Oakley's initial signing orally observation. So we go into this thing of who's signing what and all that. But her observations, child D's heart rate was, for the first few hours, the heart rate was completely normal, up to 12:30 a.m. It had peaked at 1:15 a.m., but could have been because of handling or a nappy change, or it could have been because of shock. So we see the baby on the ventilator is now in what we'll describe as compensated shock. So with the aid of the medical interventions, the blood pressure, the perfusion and the oxygenation are maintained, and there is no longer a need for the baby to be in shock. So we've gone from the shock, which is the picture of the blue legs and the cold legs, where the baby's shutting down the peripheries to shunt blood into the centre. That's the compensatory mechanisms. Now, they require a lot of energy and a lot of very complex physiology to achieve and keep them in balance. But we have that, and we have that settled now because of the ventilation. And she goes on to say, but the readings were still within the normal parameters. This, again, is not a normal baby. So if the respiratory rate or the cardiac rate was high, but still within the normal limit, it is, in the context of this baby, not a good sign. The respiration rate, she goes on, was the upper end of what would be considered ideal. So there we have it. The baby is hyperventilating, even though it's still within these parameters. It's breathing fast. So the reason it's breathing fast is because either it needs more oxygen, or it's trying to blow off carbon dioxide. And it's trying to blow off the carbon dioxide because its blood is acidic, or it needs more oxygen because the ventilation is inadequate. And then she goes on to talk about the temperature readings were completely normal, no high temperature, but don't forget the baby is in an incubator, the baby is not sustaining its own temperature. A further observation chart records the readings made for baby D being on CPAP. So we now know that the baby has been switched from the ventilation, that's the intubation, which has brought about the stability in this baby. For some reason, it's now off that stabilising factor and has been put on to CPAP, which can be just as effective and is less invasive, but it is a big event. An event to move baby from intubation to CPAP is an event. And then she goes on to say that the oxygen saturation levels were 100, which meant baby D was breathing beautifully. But baby D wasn't breathing beautifully. Baby D was breathing fast. So in order to maintain that oxygen saturation, baby D had to use a lot of energy to put in all those extra breaths to keep that near 100. And we also know that, as I've said here before, the oxygen saturation levels measured by oximetry are not always accurate. So again, we cannot assume anything about this baby. We have to look at the history. We have to look at the mother's concerns, the findings in the early stages of the birth. All of these things seem to have been pushed to the background now. And she goes on and says there was nothing she was worried about from those readings. So that is our description then of the stability in this baby. The uncertainty around all of this stuff is brushed away, and the baby is described as stable. Well, let's just go on and see how stable the baby really was. So we go on to bits of who signed who and what, and I presume I connected the fluid because we're building up to the air embolism bullshit, and we're ignoring everything that's going on here. So at 1:30 a.m., there's a desaturation. So a desaturation is I would prefer to use the word a failure to resaturate rather than desaturate. You know, desaturation is like a single event, but the failure to resaturate is a continuous event. And this one apparently required oral suction as the baby was bubbly and lost colour. So it only required a little bit of bubbliness, a little bit of saliva or fluid in the mouth to cause the discoloration. The discoloration to the skin observed, trunk, legs, arm, chin, and Dr. Brunton is called to review. So we see the baby desaturates or fails to resaturate. It immediately develops discoloration of the skin. The development of the discoloration of the skin is the triggering of the compensatory mechanisms to get all that blood into the centre where it's needed. Mrs. Oakley says she remembers being on her break, and then we go on to this whole thing about was she there, was she not, you know. And then she starts rambling about this rash again. So we get another description of the rash. This is the prosecution. Asked about the note, Mrs. Oakley said, bubbly bit for bubbly saliva. I don't know what that means. She says she does not remember specifically the exact rash discoloration, but hadn't seen it before. Now, that's a logical contradiction. You don't remember the rash, but you know you haven't seen it before. It was dark, it was unusual, and the rash struck me. Yeah. Asked to expand on that, she says, I haven't seen that rash before in a baby, and I've looked after, to the best of my knowledge, in my years of neonates, over 20 years. So what? As I've said on Twitter, even though I practiced medicine for 40 years, I used to see rashes every second day that I'd never seen before. Mrs. Oakley adds, it was unusual. So, we're now into the whole weeds of this. We've forgotten all about this uncompensated shock and compensated shock. And, we're into the weeds here on the descriptions of rashes that people haven't seen before and can't remember, but they're able to describe them even though they can't remember them. It was a deep red-brown. So now we have yet another description of a rash in a baby, a deep red-brown, different from mottling. Well, what is mottling? Can you get deep red-brown in mottling? Of course you can. You can get practically any colour in mottling, and I explained this before. She says sometimes babies can look generally white with a mottled all-over appearance. Yeah, sometimes they can. But whereas this rash was as in specific places. But that's the nature of mottling. Mottling's going to move about. It's going to take blood from one area where it might spurs another area. So generally white would mean that the entire peripheral circulation was shut down and mottled all over. This just doesn't make any sense from a medical perspective. It was just different from what I'd seen before, and that's what stayed with me. So this is the whole, get this rash thing in, get this difference thing in, get all of this in and ignore everything else. The nursing notes add saturations to 100% and O2 weaned to air. Okay, so now we've gone the CPAP and now we're taking the oxygen away. Observations satisfactory. And then she said she couldn't recall who was doing what, but the oxygen was turned up on the CPAP machine. And Child D responded, oh, is that right? And then Dr. Newby is called to review and she increases the fluids. Well, why would you increase the fluids? You would increase the fluids because you want to expand the volume of blood that the heart can beat on. We have to remember again, these are neonates. So a neonate, whereas it can increase the rate of heart contractions, it cannot increase the strength of each of those heart contractions because it is not developed enough. The myocardium, the muscle of the heart, is not developed enough. And then we go on about the rash-like appearance. The mottling had resolved between 1:30 a.m. and after the doctor's review, but of course it had because we'd now turned the oxygen up. And BBD was very stable again. So we've moved from uncompensated shock back to compensated shock. Very, very simple. So then we move on. Nurse Oakley's nursing note as 3 a.m. BBD crying and desaturated again to the 70s. Commenced on 100% oxygen via CPAP and picked up well, but skin discoloured again. But less than previously. Of course it's less than previously. You're now using 100% oxygen. And that 100% oxygen is, by the way, also adding to injury in the baby. Dr. Brunton called to review, take off nasal CPAP, further fluid boluses and gases 1 hour, care is attended to. So we're now off the CPAP. That's an event. We've gone from ventilation, CPAP with oxygen, no oxygen, now no CPAP. So this is the sequence of events. This is a baby that needs desperately that oxygen, that needs desperately that fluid. because we know its lung is not exchanging oxygen as well as it could. And we're now going to go on to explain how the inflammation is destroying the lung in front of them. Let's just get briefly to the cross-examination, because you start to get a better picture here. And Ben Meyer does the usual discussion about things, statistics, and the number of babies in the unit and all that other stuff, But then, quite rightly, he refers to BBD as an intensive care baby. So that, remember, is a one-to-one care baby. Mrs. Oakley says she wasn't a poorly intensive care baby. She was a poorly intensive care baby. And the reason that Nurse Oakley says that is because she wasn't on ventilator support. So would taking the baby off ventilator support so that it can be redesignated as not a poorly intensive care baby, would that be something that people would do if they're going to be in two places at once and they can't provide one-to-one care? I don't know. BBD was classified as an intensive care baby. The chart shows Mrs. Oakley looking after BBD in room 1 and another baby in room 2. So BBD, an intensive care baby, was not on one-to-one nursing. And Myers says intensive care babies should be one-to-one support. And the nurse says, ideally, yes. No, mandatorily, yes. Myers says the fact that Mrs. Oakley was looking after another baby that night fell outside the guidelines. Then Myers goes on to say, that isn't in the guidelines, is it? And Mrs. Oakley goes on, strictly speaking, no, but it does happen. Well, that's the argument that people are making. It happens all too frequently in this place. Mr. Myers, it's important that with babies like BBD, you remain vigilant, as they can deteriorate quite suddenly, can't they? And Mrs. Oakley agrees, yes, they can. And Mr. Myers should have went in on there and said, and that deterioration or collapse is not always due to our embolism, is it? But he didn't have anyone there to advise him to do that. Mr. Myers asked if Mrs. Oakley was aware BBD had been on a ventilator until the early hours of June the 21st. So the baby's on a ventilator until the early hours of June the 21st. And she said she only knows that from the medical notes. He asked her if she knows there was a delay in giving BBD antibiotics after birth. She says she cannot remember. Of course she can't remember. We're not talking about rashes now. But she can see from the notes. Mr. Myers refers to a nursing note from June 21st during the day when there were signs of respiratory acidosis after extubation. Okay, so now we have respiratory acidosis. That's the baby blowing off carbon dioxide in the blood, unable to get rid of it, blowing it off, making the blood acidic. What happens when you make the blood acidic? Well, one of the first things that happens when you make the blood acidic is you screw up with all of the physiology of the body. It has to operate within very tight limits of acidity. And one of the particular organs that it hits really badly is the heart. So the heart can't beat properly when the blood is acidic. But once we have made the decision here to extubate a stable baby, we have produced respiratory acidosis. That's a major event. Mrs. Oakley says she cannot remember that note, but she would have been told about it during the handover. Myers refers to the note continuing, blood gas repeated 2 hours later showed a further deterioration with increasing metabolic acidosis. So the metabolic acidosis is now the anaerobic respiration. So now we are in a situation where we cannot control the carbon dioxide and we cannot control the oxygen independently. We cannot control respiration. We cannot control respiration. We cannot control energy production. We cannot control energy production. We're going to lead to death. That's what's going to happen. So Mr. Myers asks about the attempt to take BBD off CPAP at 7:15 p.m. But the baby began to shallow breathing again and was put back on CPAP. So why in the name of God Would anyone want to take this baby off CPAP at 7:15 p.m. when we already know that we induced respiratory and metabolic acidosis when we took it off intubation? So every time we're stepping down the respiratory support, we're going to get worse. And then he goes on to say, we have a baby who is struggling to breathe unaided throughout the day. And Nurse Oakley admits, yes, these are all events for which Lucy Letby was not present. We have a clearly deteriorating baby with a clear reason why it's deteriorating. Pneumonia, sepsis, inflammation, hypoxia, acidosis. We have all those things, none of which were discussed. And he goes on to say, for context, in the previous 24 hours, showing BBD's observations were in the warning zone for heart rate and breathing rate, which is precisely what you want when you're trying to treat these babies. You want those warnings, but you have to act on them. For several hours, observations reading from late June 20, that's the day the baby was born, throughout the day of June the 21st. Blood gas readings are shown to the court. So these are June the 21st, 10 a.m., acidotic blood, afternoon, acidotic blood getting worse. Mrs. Oakley agrees. She adds that doctors would have a better idea of the parameters. No, we don't need to know what the doctors know about the parameters. The pH was 7.19 and 7.17, which is catastrophic. The pH has to be above 7.35 or the physiology doesn't work. Mr. Myers refers to reasons saying the situation is not as good at 11:52 p.m. as it was at 6:44 p.m. And Mrs. Oakley agrees. So Mrs. Oakley agrees that this is not a stable baby. Mr. Myers says the blood gas readings are worse at 1:14 a.m. and point to a deterioration. So we're getting close to the time now where this baby is going to completely collapse. We're getting declining blood gases. We're getting mixed up and messed up with ventilation strategies, and we're not coherently approaching the management of this baby at all. And she says the doctors would take action based on them. Mr. Myers refers to the break, and then we go into the break and the handwriting and all that kind of stuff. But we know what's going on here. And they start talking about this rash again, and, again, it's just irrelevant to what we're talking about here. Mr. Myers is referring to the 3 a.m. collapse at Baby D, and he suggests that Mrs. Oakley was present at the time of the collapse. Mrs. Oakley says she would have been in the vicinity at the time. Well, she was the designated nurse for the baby and does not remember what she was doing. Mr. Myers says it was an episode which resolved quickly and resulted in a decision to take the baby off CPAP. So again, we have a collapse and we have a decision to reduce ventilation. Not discussed during the trial at all. Mrs. Oakley, of course, doesn't remember, but she remembers the rash. And then, yes, we get pop-up prosecutor Simon Driver asks about the discoloration to the skin at 1:30 a.m. as if that matters a damn, because every time you respond appropriately by reperfusing the baby, the rash goes away because it's mottling. So let's just briefly go through a little sequence of events that should have been presented in a slightly different way. June 20th, ascending infection, colonization of the membranes, invasion of the amniotic cavity, bacteria penetrating the amnion, fetus becoming infected, and the fetal inflammatory response, also as FIRS, is triggered. So that's all before we get anywhere near the neonatal unit. So we also know, and I'll leave you the reference, that bacteria are not necessary to trigger this inflammatory response in utero, that you can have what's called a sterile inflammation. And it seems there's mounting evidence that now supports the concept that ensuing neonatal immune defects reflects the effect of inflammation on immune programming during critical development in the baby. So this is a kind of genetic problem, and it leads to chronic inflammatory disorders later in life, as well as vulnerability to infection after birth. It's important that the classical signs of, malodorous amniotic fluid or elevated white cell counts, all those things that we would associate with chorioamnionitis, they don't have to be there to induce the inflammation. We now know that the inflammation is a separate component of the fetal response. So everything can look normal, but this inflammation is raging out of control. We also know that the symptoms of pneumonia in neonates is respiratory distress, so tachycardia, retractions, grunting, all the things the mother described, cyanosis, lethargy and poor feeding. I tried to bring the baby to my breast, temperature instability, up and down, present, tick, it was there. In severe cases, sepsis and multi-organ failure, and chest x-rays showing infiltrates, but they don't all have to be there. That's the problem with all of this stuff. So the newborn's immature innate immune system, that's the kind of built-in immune system, tries to respond to the pathogens first. But there aren't really enough cells in the lungs in particular to really do that, and particularly a type of cell called a macrophage. And the great thing about macrophages is that they will eat the bacteria, but they won't let the breakdown components of the bacteria escape into the surrounding tissues and induce even more inflammation. And you get neutrophil recruitment. So these are the most multiple little white cells in the body, and they will come flooding into the area. But again, that doesn't happen so well in neonates, and the neutrophils are not as effective. But you start straight away with cellular injury, particularly in the distal airways. So that's the gas exchange airways. And the injury that injury itself then can lead to the respiratory distress. And what's worse, the infection can inactivate existing surfactant. That's the stuff that's holding the lungs open. It damages a type of cell called a type 2 pneumocyte, and that's the cell that makes the surfactant. So the surfactant that's used doesn't get replenished. And this makes the respiratory distress worsen. And then you get the systemic spread beyond the lungs, into the heart, into all of the other organs of the body. So what happens if you have this acidosis, which we know has been going on for hours? Well, you get an increased respiratory rate, and the body is trying to compensate. It's trying to blow off the CO2 and correct what other systems within the body should be correcting. But the acidosis impairs cardiac function. That's the big problem. It affects the central nervous system, and that's what leads to the lethargy and the poor feeding, and sometimes even seizures. And the more severe the acidosis, or the greater the duration, the worse is the outcomes. And of course, the gestational age and all those other things have to be taken into account. Now, a lot of papers would indicate that acidosis below 7, remember we are very, very near that point, are very important pointers to mortality. There's another thing that we have to consider that wasn't talked about, and that's pro-inflammatory cytokines. So a cytokine is a signaling protein used by the immune system to turn different parts of it on and off. And when neonates in particular get infections and inflammation, they produce a lot of these cytokines, not in a very orderly way. So you're trying to produce a balance between pro-inflammation and anti-inflammation, and that is 50-odd cytokines. So you can see how difficult that all is, but that is not developed well enough in babies. So the neonatal response is often deregulated compared to adults. So you have this catastrophic tissue destruction, which you don't want to have. You want controlled tissue destruction, which can be repaired, all of which takes an enormous amount of energy. So I think if you all look at the timelines, if you look at the decision, ventilate, don't ventilate, CPAP, don't CPAP, oxygen don't oxygen. The other problem, which needs mentioned, is reperfusion injury. So if you paradoxically resupply oxygen to an area that has had no oxygen, that hasn't had enough oxygen, the reperfusion of that actually injures the cell itself. So this stop-start, oxygen available, oxygen not available, is in itself, through a mechanism called reperfusion injury, causing the type of changes found at postmortem. So this shows why there needed to be a witness for the defense in the Letby case. We can draw the timeline whatever way we like, depending on what was happening physiologically, biochemically inside this baby, without reference to text messages, WhatsApp searches, or anything else, because that is what modern scientific medicine does. And all of this is missing in this trial. It's missing the entire point of pathology. So I hope that was instructive. It's a lot of stuff to squeeze in, and I don't want to bore people to death, but it is critical that all of this stuff should have been explained. So in the next episode, we're going to get on to the expert witness accounts of events, none of which are going to mention perfusion, reperfusion, inflammation, cytokines, or anything else. They're just going to mention rashes, no doubt, deliberate actions that no one actually seen. I'm sure. I haven't gone over them yet, but I'm pretty sure I know what they're going to say, but it isn't going to include anything like what I've just said. So I hope this was helpful. I'll see you in the next episode. Bye.